Hello. I'm here to talk to you today about patient concordance. Now, it's a pretty new term, but make no mistake, this is an age-old problem. My name is Dr. Sarah Jarvis. I've been a GP for 27 years, and for 22 of those, I've been a GP trainer as well. And in the course of my training, we spend an inordinate amount of time in tutorials with registrars, talking to them about communication skills, getting them to put them into action, and of course, discussing the importance of patients having informed decisions in terms of engaging them and getting them to continue, adhere to, concord with their medication or any treatment plans. So, without delay, let's move on. Compliance, adherence, and concordance. What is in a name? Well, when I became a GP about 28 years ago, almost all medicine was reactive. We assumed that patients did what we told them to do. Why on earth wouldn't they? We were the doctors. We knew best. So what happened was the patient came in with symptoms, not for health promotion. They didn't come in unless they were ill. We asked them questions. If we were very lucky, or they were very lucky, we occasionally asked their opinion about those questions. We examined them. We did investigations as we thought appropriate. We then came to a diagnosis and we prescribed medication. The patient, of course, took the medication because, after all, why would you come and see a doctor if you weren't going to do what they told you to do? The patient, therefore, got better because medicines always worked. And then the patient stopped their medication because they had got better. That's the way it was. And I genuinely believed, certainly when I was a child at the age of 8 and the GP came to our house and gave my father an injection and, in an incredibly politically incorrect but inspired move, gave me the needle and syringe, which I then used to practice injecting my teddy bear with Ribena. That was what inspired me to become a GP. And of course, at the time, I thought he was God. It was an extraordinary experience for me. What I've very much had to learn since then is that things are a little bit different. Consultation models way back then were very much in their infancy. And of course, we don't want to go back to those bad old days of the doctor-centric consultation. The internet, however, has, of course, made everybody an expert. And there are times in my consulting room when I wonder if the pendulum has swung just a little bit too far, not just for our liking, but for the good of patients. Today, patients can come in with information they've downloaded from the internet, and of course, they are completely convinced that they know best, because the site that they've been to promises something that is too good to be true. What they often fail to realize is that if something sounds too good to be true, it usually is. So sometimes when they come in to see me today, they are there because they want me to do what they want. And if I don't, they believe that I am getting in the way of what they, quote, need. Indeed, very recently on Radio 2, on my regular show, a patient rang in and queried the medication for secondary prevention following myocardial infarction. I asked him what his issues were, and he said, well, they've given me far too many drugs. They've given me aspirin and clopidogrel. They clearly don't know what they're doing. They do the same thing. It transpired that the patient had simply decided that because both aspirin and clopidogrel performed a similar function in terms of coagulation, that the doctors clearly didn't know what they were doing, and he had stopped every single medication that they had given them. I was inundated on social media with people saying, how dim was he? But my response to them was, we have no idea what was going on in his mind. He may well have had health beliefs that we simply didn't get, and that clearly the doctors who spoke to him at the time didn't get. Not because they were incompetent, but because they often don't have time. I really hope that I was at an advantage because he had articulated what his concern was to me on air. so I was able to talk through the options and talk to him about his perceptions. But more of that later. Okay, so let's think about those definitions. We started off, of course, with compliance. And compliance was a very paternalistic concept, the extent to which a person's behaviour complies with medical advice with respect to drugs, the degree of correspondence between the actual dosing history and the prescribed drug regimen. There could not be any less patient involvement in it, apart from, of course, actually popping the pills. So we moved on. And as I said, about 10 years ago, we started talking about adherence. This has a wider remit. This relates to lifestyle as well as drugs. But here, the fundamental difference perhaps is that we acknowledge that the patient has choice, but it's still dependent on them taking our advice. Concordance is another matter entirely, the buzzword of today. This is all about buy-in. This is about equal partnership. This is about shared progress towards a decision, and then supporting the patients at all stages thereafter. So let's just look at the differences, and let's see how those progress has happened. Again, when I first started training, we just about started looking at ICE, ideas, concerns, and expectations. It seems incredibly dated now, but at the time, it was really revolutionary. Then, as my registrar started to take the MRC-GP video examination, we started to look at how they could explore the patient's health beliefs and the fact that there is an extraordinarily wide variety of reasons for lack of patient buy-in. From our patient on the radio who had a myocardial infarction to perhaps the patient who comes in to see you with a cough in the middle of winter. You've seen 8 patients that day who want antibiotics and you're having to fight with them because you need them to understand that they don't need them for a viral infection. How are we going to know? It's very easy to assume that the 9th patient is there for the same thing, when in fact, of course, they've lost a relative to lung cancer and they're terrified that that's what they've got. It's an easy example of a patient's health beliefs varying from our own and how it's so easy for that mismatch to adhere. So with adherence, the patient has an informed discussion. They come to an informed decision and they then agree on the basis of being provided by us with all the information they need to make the right informed decision, which is to do what we've asked them to do or told them to do, where the old terms are concerned. So then let's move on then and think about concordance and how that changes. The two are not interchangeable. This is very much an open discussion. The patient is an active partner. It's a much broader process. It's an open discussion regarding medication taking, but also regarding every stage, not just when they're in the consulting room, but what they're going to do when they leave, support for the patient. It's cradle to grave, if you like, as far as medication is concerned. We need buy-in at every stage from the patient, because if we haven't convinced them by the time they leave the consulting room, then they are never going to remain convinced 10 weeks, 3 months, 8 months down the line. So, in summary, names matter, not because of what they are, but because of what they need and what they mean. The patient and the doctor have to be equal partners. And we'll be looking in a moment at quite why that is so important and why we may assume that we're there for the patient, but in reality, we are there very little indeed. In the next section, we'll be looking at the size of the problem of concordance and what that means in terms of patient outcomes.